just to remind you of William Ose's comment about the pneumococcus being the captain of all men of death. And when we trained, we learned that it was a consolidation, a kind of consolidated pneumonia, often taking this kind of appearance. And this is one of my patients from way back when she presented with the pneumococcal pneumonia. There was also pneumococci in her blood. And about a month later, you can see that in that case, and her CD4 was about 5, it led to with a necrotizing, it was a necrotizing pneumonia in this HIV context with breakdown in pneumatoceles. They are lancet-shaped diplococci on gram stain. You really can't see the quelling reaction terribly well there, but it's an antigen-antibody reaction. We often now diagnose the pneumococcus on culture, particularly on blood culture, and that's a bit of a history of the pneumococcus isolation. Thought maybe you might recall with the H1N1 flu epidemic of a couple of years ago, 2009, a number of those people who died in the United States, in fact, at autopsy, had evidence of pneumococcal, secondary pneumococcal infection that in fact led to their demise. The pneumococcus is very, very important in terms of Africa and in terms of HIV. And this particular review article reminds us that we have penicillin sensitive or intermediate and penicillin resistant strains. The first resistant strains were described by Keith Klugman and Hendrik Kurnoff back in around about 1970s, 80s here in South Africa. Penicillin, the treatment, even with resistant high-dose penicillin, and you'll see the doses there, particularly 6 to 10, normally high dose around about 20 million units a day for high dose. And alternative treatments, that's for sepsis in the lung, and then sepsis which is beyond the borders of the lung. Again, these are the kind of third-generation cephalosporins and high-dose penicillin. A study from a few years ago from Denmark looking at community-acquired pneumonia in HIV, small numbers of HIV people in Denmark at that time, and this is a population who are HIV negative with pneumonias, and you'll see that the incidence really in the HIV population has decreased over time, and we'll come to that in a moment. With antiretroviral therapy, there's been a significant decrease in the incidence of pneumococcal pneumonia and community-acquired pneumonia in particular. And then with CD4 counts that are higher than 500, also you'll see that the incidence rate becomes quite low, almost similar to the HIV negative population. 2.4 in 1,000, 5.9 in 1,000. 5-year risk, even after the start of antiretroviral, is still significant. So patients on antiretrovirals still have a risk of developing community-acquired pneumonia. This is data from Liz Corbett and Gavin done a few years ago, and you'll see that I put this in because these are admissions to the hospital, and this was, as I recall, the Ernest Oppenheimer in Welkom. Most of their patients back then, 10, 12 years ago, were TB, but this 18% pneumonia, a third of those were pneumococcus. So pneumococcus is actually very important. This was from Francois and others, Alan, Neil, here in Joburg, looking at a autopsy group of patients, about 50 of them, and again, and really demonstrating that although these people had a pre-mortem diagnosis of TB, nonetheless, a number of them had additional pathological processes, including community-acquired bacterial pneumonia. This I found was quite an interesting comment a few years ago. looking at Africa and looking at Asia and seeing the difference between those two continents, where we were finding back then, this is now Senegal, very little pneumocystis. They were finding a lot more. I think, I'd be interesting to know what Cindy, Francois, Prudence, the other clinicians in the group think, but I think the difficulty in making that diagnosis has been our problem, because a few years ago we used to say, well, we don't see it. But that, I think, is nonsense. I think we see just as much in our wards. We're seeing a lot of pneumocystis. So we're going to talk about vaccines in pneumococci in the next 10 minutes. And I want to remind you that there are two groups of pneumococcal vaccine. The pneumococcal polysaccharide, which we give to adults, and which has been around for a good, probably about 30, 40 years. We've had this vaccine. It induces immunoglobulin, B-cell response. And so you kind of have to have an immune system that can do that. So the polysaccharide pneumococcal vaccine, which is, utilizes 23 of the most invasive capsular serotypes, kind of doesn't work all that well in little children and in elderly people and in the immune compromised, because you have to have an immune system that can, as I say, develop those B-cell responses for you. And it's always been a problem, because over the years, when we only had this back 20 years or so ago, we often kind of were disappointed with the effect of the 23-valent vaccine. The second group of vaccines, those are the pneumococcal polysaccharide vaccines, what we call the conjugate pneumococcal vaccines, came in about 10, 12 years ago, and really came in with a lot of storm, a lot of noise, and I think a very interesting group of vaccines that we'll look at in a moment. These are polysaccharide protein linked, and they seem to have a greater potency in terms of producing an immune response, because they target the T cells. Not just B cells, but in fact, they target the T cells, dependent pathways, and they are much more immunogenic. You'll see that we've had a number, 7-valent, 9, 11, and most recently 13-valent vaccines. Looking at the serotypes that are present, most of this was developed in the developing world. We've taken it over, obviously, for Africa and Asia, developing world, where pneumococcal infections are a big problem. But in fact, we are using just 7 and 9s in most of Africa, and in fact, because of the expense of the vaccines, we are not using them throughout, we're not using them prophylactically in the population as a whole. So this is really Shabir's presentation. And he's divided it up into the epidemiology of pneumococcal disease and HIV, pneumococcal vaccines in children, and pneumococcal vaccines in adults. And what he shows us in this first slide, looking at the HIV positive in blue and in the black, the HIV negative, and you can see that pneumococcal, and this is bacteremia, is a problem of children. You can see the numbers there, this massive kind of number virtually kind of overcrowds the adult group and the elderly group. So it's really a disease of the young. Furthermore, what you're seeing here, this is invasive pneumococcal disease, with the introduction of antiretroviral therapy, and you'll see the dates here, that this is kind of when we were introducing antiretrovirals, you'll see that very clearly there's been a decrease. I want you to look at that we've got blacks, Hispanics, and whites decrease, and particularly a significant decrease in the black folk in America. And if you look at the HIV negative group, or the population as a whole, and you'll see that 10 to 15 in 100,000 get invasive pneumococcal disease, compared with the HIV group here of 500, you can see that the risk of invasive pneumococcal disease is about 35-fold greater in these adults, even during the antiretroviral era. So in other words, even now, when we have good antiretroviral therapy, we still have a problem. These are the pneumococcal conjugate vaccines, 7 and 6A. Those are the serotypes that they've looked at. In green, the non-serotypes there. And we look at antiretroviral access on the burden of invasive disease in children. And you can see again that there's a decrease in time with the introduction of antiretroviral therapy. In this one here, burden in South Africa, again, this is adults as opposed to children in particular, and again, with the establishment of antiretroviral therapy, there's been a definite decrease, both of the vaccine group, 7 and 6A, and also the non-vaccine. And I think what Shabir is really saying to us is that with the introduction of antiretroviral therapy, there's kind of been a global decrease in the prevalence within HIV people of the pneumococcal disease itself. So that's the epidemiology of pneumococcal disease in HIV populations. And so let's look at pneumococcal vaccine, particularly in children. This is one of the early studies back in 2003. And just to say that Shabir and Keith Klugman are kind of the two of the big names in this particular field internationally, Shabir Madhi and Keith Klugman. Keith, as you know, lives and works in America nowadays, but these are obviously South Africans. So, and Ntombe also from Wits as well. So this trial of a 9-valent, taking 9 of the common serotypes and conjugating and producing a vaccine. What the efficacy is, and you're looking at vaccine in blue, vaccine efficacy in the HIV-infected group and the HIV-uninfected. The vaccine is more effective in the uninfected HIV-negative. But there is nonetheless effectiveness in the HIV-infected as well. And what Keith and Shabir are showing is that the prevalence rate of invasive pneumococcal disease is that much more high in the HIV-infected, so that, in fact, the burden, the absolute burden that has been prevented is that much higher, so much more. So although it looks as though, when you look at the face of it, that the numbers are less who are protected, but in reality, because invasive pneumococcal disease is such a problem in HIV children, that in fact we are preventing pneumococcal disease in far higher numbers. And he has this rather delightful picture of a macrophage trying to eat a strep pneumonia, and because it's got this big fatty kind of capsule around it, it's kind of hard to grab onto. So in point of fact, and that, remember, is one of the reasons why the pneumococcus is so bad, so nasty, because it has this protective capsule around it. And our macrophages and our polys, our neutrophils, cannot deal with it well. So how do we deal with it? Well, we deal with it by producing appropriate antibodies and T-cell responses. And this is kind of a complex picture, but what we're looking at here again is the conjugate vaccine with 9-valent, and he's given us several of those serotypes. And what has happened here is that there's been, following a series of vaccination, in the absence of antiretroviral therapy, what happens is that there's reduced immunogenicity, and in red is the effect of the HIV-infected. So HIV-infected children do not, even with this vaccination, they do mount an antibody response that can be measured in red. This is in green, those who are uninfected. They mount a far better response to the vaccine. But without antiretrovirals, the kind of effect is somewhat muted. Okay. So in other words, antiretrovirals are a necessary part to be effective. So why do we need those antibodies? Well, those antibodies you're seeing here sit on the surface of that capsule and make it more desirable. I look at it as like, if you're going to eat a McDonald's, then put plenty of tomato juice on it or tomato sauce. Kind of make it palatable or something, so that you won't kind of taste the stuff as it goes down. So this is kind of what the body does. It kind of covers the bug and makes it digestible, kind of pleasant for the body. So you're very happy with the pneumococcus sitting inside the macrophage. Well, HIV-infected children, less likely to have these antibodies following that primary immunization with the 9-valent. And in fact, what he's showing you, the infected, the uninfected, and showing you very clearly with these p-values that he's quite right. The 19, the 6b, 23, we don't mount an appropriate response, unfortunately. A reduced long time, so not only do we not mount an appropriate response, but in the long term, those antibodies that we do get, we tend we tend to lose more rapidly in the HIV-infected child. So in terms of then antibody concentrations, they're sustainable in infected children 5 years after vaccination. And again, you're seeing in the yellow, these are pre-boost. This is HIV negative, this is HIV positive, and you haven't boosted. And you see that 5 years down the road, the antibodies to the pneumococcus are relatively few. So that the sustainability of your vaccination in the absence of antiretroviral therapy with your HIV child is not maintained. So we've looked at the epidemiology of the pneumococcus. We've looked at the role of the vaccine in part in children, and we're now going to quickly look at the effect of antiretrovirals. And in reality, here the immune response to the conjugate vaccine and HIV-1, similar to the uninfected. Most of them are on antiretrovirals, and in this graph, if you look at it, kind of eyeball it, they're the same, whether they're negative or positive. And the effect of exposure and timing of heart, what you're seeing here is HIV-positive youngsters on antiviral therapy, that's the red circle, compared to the HIV-positive not on therapy, that's the kind of bluish circle. And here is the maternal, the mother and the infant. Here the mother is positive, infant is negative, and the mother and the infant negative. So the effect of HIV exposure, pretty much the same in all of those in the immune response to the pneumococcal conjugate 7 vaccine. The effect, however, of HIV exposure and timing of heart on qualitative antibody responses, and you'll see in that group who are HIV positive, a child who is not on antiviral therapy, that the antibody response in these infants is clearly, to all of these different serotypes, is reduced compared to those on antiviral therapy and those infants who are HIV negative. What Shabir is showing us here is that the qualitative serotype-specific antibody responses associated with the CD4 nadir before heart and the CD4 at the time of vaccination is important. So that the nadir group, and he's divided those groups here, the nadir and then those at the time of vaccination, you can see that there is a far better response, particularly with the higher CD4 percentages, both as a nadir and at the time of vaccination. So giving antiretrovirals makes a major impact in the lives of these children. Then finally, the last minute or two, pneumococcal vaccine in adults. So in children, we give conjugate vaccine, 7, 9, 11, 13, looking at the different serotypes. Is it valuable? Yes. Does it work? Yes. But it works particularly in the context of antiretroviral therapy in our kids. What about adults? Well, the pneumococcal polysaccharide vaccine increases the risk of pneumonia. And I remember reading this particular from Neil French back about 10, 12 years ago, and kind of being fairly puzzled by this particular study, where they gave vaccine in Uganda, and they did something similar in Kenya, and in fact, more people died on that vaccine trial than in the placebo arm, in the arm that didn't get vaccine. And it kind of puzzled all of us in terms of trying to understand what was the vaccine doing. So initial double-blind, randomized, placebo-controlled, this was the polysaccharide vaccine, not the conjugate, the polysaccharide, that requires immunoglobulin, your ability to produce antibodies. There was an increased level of invasive pneumococcal disease after it. There was particularly vaccine-related serogroups were involved. So even having given the vaccine, the 23-valent, in fact, vaccine-related serogroups were a risk to death, and all caused pneumonia and detrimental effect, particularly in the first 6 months. Interestingly, the follow-up of this particular study with Neil showed 5 years down the road that those who had gotten over their vaccine actually did better in the long term. So again, there's clearly something happening within the immune system that kicks in at a later stage. So unexplained survival benefit for vaccinees, as I say, this occurred particularly with higher CD4 counts, but at a later stage. Incidence of invasive pneumococcal disease and all-cause pneumonia in HIV-infected adults in the USA. This is invasive pneumococcal disease and pneumonia episodes. Yes and no. What we're looking at, cases per 100,000 incidents, and this is those who've received the polysaccharide vaccine in the past 5 years. If you've received that vaccine, yes, then there is a reduction, some level of reduction in the future invasive pneumococcal disease later on. This is again the polysaccharide vaccine and pneumonia incidence, but looking now at viral loads and CD4s, and you can see that lower viral loads tend to be protective, which is understandable, and higher CD4s in yellow tend also to be protective. So kind of from a point of view of vaccinating adults with, say, the 23-valent vaccine, you want to kind of vaccinate them with lower CD4s, so again on heart, and with higher lower viral loads and with higher CD4s. This is the 7-valent now, looking particularly at the conjugate vaccine in adults. And this has been an area of controversy. And I was looking at reading that last night. Again, Neil French's work of does the conjugate vaccine that we give to kids help in terms of adults? Efficacy of 2 doses of that conjugate vaccine in adults who are HIV positive in terms of controlling invasive pneumococcal disease. Well, compared to the placebo, there does seem to be some level of control. But when we get to death, and death from any cause, there's no evidence that the conjugate vaccine is better than placebo, unfortunately. But are there fewer vaccine serotypes, CD4 cells, and so on? Is there some evidence maybe of help? Maybe. But at the end of the day, if you're going to look at death or mortality, the conjugate vaccine in adults who are HIV positive doesn't appear at the moment to work particularly well. So that people are now putting together both the polysaccharide, the 23-valent vaccine, and giving it together with a conjugate. And I was reading last night a recent report that again shows no real benefit in adults. This is the vaccine types and the non-vaccine types carriage in pneumococcal vaccine recipients, and particularly you'll see that when we give the vaccine, there is a decrease in carriage of those serotypes in the mouth and the back of the nose, and so the vaccine does seem to eradicate the major pneumococcal subtypes that cause disease. But there is, if you look at this particular column here, generally speaking, an increase in the non-vaccine serotypes. So in other words, you replace the vaccine, the invasive organisms, with others. And the question is, what happens with those new pneumococcal strains that come in? Do they become invasive, and do they cause trouble in the long term? Well, if you look at this group, herd protection, which is a very nice study, you'll see that there is a decrease. So this is a 7-valent conjugate vaccine that we give to our kids, and we're looking at a population under the age of 5, and you're kind of seeing an effect in all of these, particularly in the elderly, that when you're vaccinating our kids, that people kind of getting into my age group and older, we get protected by the grandchildren and the others who've been immunized. So there's a herd effect. So we are not immunized, but because the kids around us no longer are carrying those strains in their mouth, we in fact are protected. And this in fact just says the same thing. There's about a 2.2-fold improvement in the community. So in other words, if we were to vaccinate our children in South Africa, we would decrease for the population by about a 2.2-fold the level of invasive pneumococcal disease. And the indirect effect, you're seeing again, this is in the USA, of a decrease in any serotype. Certain ones, this is 7 related. There's been clearly, and these are the different, as I recall, different serotypes, 7. There is a very definite decrease. But what you're seeing here is the non-vaccine related types, there's an increase. And we don't really know what that is going to mean in the long term. So conclusions, antiretroviral therapy reduces the burden of invasive pneumococcal disease. However, there's a 35-fold greater risk nonetheless in the people even on antiretroviral therapy. Optimal vaccine schedule for children, we kind of know that, but we don't know what is best for adults at this moment in time. Heart associated with improved antibody functionality and durability, so that antiretroviral therapy together with vaccination certainly needs to be carried out. Potential of pneumococcal conjugate vaccine for reducing invasive pneumococcal in HIV-positive adults in developing country through indirect but herd protection. So that should we be immunizing the population in South Africa? In Africa, probably yes, the kids, the children, so that their adults, their grandparents, their parents will be protected. Thank you very much.